Hello, the lovely CAM followers. It is a pleasure to be here with a very amazing guest tonight. I'm very happy to introduce the lovely Sarah Heath, who's been here before. So please do go and dig out the Facebook Lives because you will be blown away. Me and Evie have been like prepping ourselves because we know that we're going to be terrified of the amazing things that come out of our mouth. And we'll be like, really? Oh my God, say that again. So I am really, really excited about tonight. Just before we allow Sarah to introduce herself, I do want to do an absolute blatant promotion for our children's book. Sarah has actually even endorsed this. It's an illustrated book to try and help people identify the signs of pain so that people will understand when their pets' behaviours changed and not assume the worst and have horrible things like rehoming or even euthanasia take place. It was driven because I have had to put many dogs to sleep whose behaviour changed substantially and the family have lost faith and there hasn't been any other options. And I do not want that to happen anymore. So please do go and look for our lovely children's book. It's called Why Don't You Listen? It's available from the CAM shop. All funds go back into CAM. And the amazing, beautiful thing about this story, the illustrator did it for free because we helped him with his arthritic dog. So it's a really beautiful story. Right, now let's get back to the point. Sarah, please introduce yourself so everybody goes, oh.
My name's Sarah and I'm a vet. I work in specialist behavioural medicine, which basically means that I deal with behavioural medicine is the veterinary discipline that deals with the health triad. So it deals with the fact that health is more than just physical health, that there's also an emotional and a cognitive component to it. So we deal with patients who have physical disease with emotional impact and also individuals who have emotional disorders that lead to behavioural change or actually influence their physical health. So it's quite complex because the way the three things are all kind of intertwined with each other and related to one another. So I run a referral practice. We are 3 vets and 3 rehab coaches. And we also have a great admin team behind us as well. We couldn't do anything without them. So it's a small practice. There's only 13 of us all together. So it's a small practice on scale of lots of practices these days. And yeah, we're a referral level for behavioural medicine, but we also do in-house chronic pain management. And that's been for the last, I don't know, 7 or 8 years now, that we brought all our chronic pain management in-house, and we now have a veterinary physiotherapist on staff as well. So we do our own physio and we do a lot of gait analysis, a lot of pain assessment, and we do multimodal pharmacological pain management as well. We do that within the practice rather than going back to GP.
Why did that happen? Because I know, I can understand from your perspective, it's really difficult, isn't it, communicating in different bases, what you're seeing and what you feel. But is it busy? And
I think it's because we detect it probably much more commonly than general practitioners do, because we see the animal in the home. We also see the animal at our rehabilitation centre where we've got enclosed exercise paddocks where we can see them off lead and we can see them interacting at very different levels. And we've got a stance analyzer as well, so we can look for abnormality in weight distribution through the 4 limbs. So we have facilities to do a bit more than the GP does in terms of detection of chronic pain. And then we also found that sometimes caregivers struggle a little bit in realizing that pain is there because it's not a classic presentation of pain. I think we tend, even when we say the word chronic pain, we still tend to think orthopedic, and that's not by any means the only source of chronic pain. So oral mucosal pain, periodontal disease, abdominal pain. I'm dealing with a dog at the moment with mysterious abdominal pain. So visceral pain through the bladder in cats. We're going to talk about cats later. So there's pain is not just orthopedic, but also, even if it is, in the early stages before you see radiographic changes, there will be pain. So if we can pick these things up much, much earlier, and we have better facilities to do that than a general practice does, because the general practice is very, very, very difficult, if possible, to diagnose chronic pain in a consulting room situation in a routine 20-minute general practice consult. So I think that was one of the reasons we had a very good detection rate within our team. And then the thing that became a little frustrating was trying to get a caregiver who was still, really needed the pain relief trial to be convinced there was a problem. So we use a lot of trial medication to put them onto pain relief and monitor their behavioural change or their physical health change as a result of that. And if we weren't doing that, we hadn't got the caregiver totally on board, understanding they were in pain. We were sending them back to a general practice saying, we are very suspicious of pain, please can you put them on a pain relief trial? And then the caregiver was going and saying, but I don't really think it is in pain. So then it's difficult for the GP vet to then prescribe pain relief if the caregiver is actually saying, no, I don't really think he is.
Yeah.
And then also we found that some veterinary practitioners also would then do a clinical examination, have no resentment to palpation, couldn't identify a limp or a lameness, and they then said, nah, I don't think it's in pain. And then the animal didn't get on a pain relief trial. Whereas now, because it's all in-house, we suspect pain, we put them on a pain relief trial, and then often that is the convincing point for the caregiver. Mm-hmm. And then we may well, if the behavioural side of things they were originally referred for becomes resolved, we can send them back to the GP on pain relief with a caregiver who believes and understands the animal is in pain, and then the vets are quite happy to carry on with that pain relief. But the other way around, it really wasn't working.
No. Sorry, just I'm actually on call. Evie is just going to go and deal with it. So that means that's great. But no, I just want to expand this pain trial a little bit as well, because I want people to realise how complex this is, in that you suspect pain, you've got to try and identify what kind of pain, in what region, what's the most appropriate medication or combination of medications, what's the timescale for those medications to possibly have influence. How are you going to prove to that caregiver with all the learned behaviours? So what timescale with the behaviour modifications? It's an absolute mind mess.
It's a minefield. Yeah, it is. I think the most important thing as well, we're very commonly dealing with chronic pain. So we're a referral veterinary practice for behavioural medicine and chronic pain management. We don't deal with surgical patients. So we're not, or accidental injury or trauma or those sorts of things. So we're not really involved with patients who have acute pain. We see individuals who've had acute pain badly managed and then have a chronic pain as a result. So we do see those individuals, but we tend to see the ones who have chronic pain, whether that's come from acute pain originally or whether that is a chronic pain condition. And one of the things we have to always remember about chronic pain is that chronic pain is actually in the brain. It's not in the lesion. So chronic pain is a difference of interpretation of pain. So the chronic bit comes from the fact that it has to be present for 3 months or longer to be defined as chronic pain. But actually the big difference with it is that it's a perception change. It's the way the brain processes the information that's coming from the peripheral organ, skin, visceral, joint, wherever it's coming from. And that's because of two processes of peripheral and central sensitization, which is, think about sensitization as kind of like turning up the volume. So instead of the message coming through as a little whisper, which it would do if you had, acute pain, you can get loud acute pain as well, of course, but chronic pain is about gradually turning up that volume to the point that it's actually unbearable what's coming through. So you know when you put radio on too loud, it's not pleasant anymore. So it could be your favorite track, but if you've put it on too loud, it could actually be unpleasant. And that's what chronic pain is like. It's unpleasant for the individual, but it becomes a point where it may not be directly locatable in terms of the original origin of it. And that is something I think is very difficult to understand, that you don't always find a lesion. There may not be anything to find in the peripheral body, because the brain has now taken over and misinterpreted those signals that are coming. So when you look at the lesion, and veterinary surgeons may do this, and they take an X-ray and go, oh no, that won't be painful, that's really mild. What they're looking at is the physical lesion, but what they're not doing is remembering that the brain is where that information will be processed, and the significance to the individual comes from the brain. It doesn't come from the lesion. So what you need to remember is that there's a disconnect in chronic pain between what you see on an X-ray or what you feel on palpation on a clinical examination and what that individual is actually interpreting by the time it's gone through this abnormal brain process, which has become sensitized, is not directly correlated with what you are seeing. I think that makes chronic pain so difficult to really comprehend. Yeah.
So difficult. And as I say, it's also not a switch. You know, you can't go, I think pain, I'm going to put on this drug. Oh, I'm the winner. You know, it really is a case of methodically unpicking. And I think for me, I'm only just really on the start of my journey. The conversations that you have, the communication, the really trying to convince the owners, I really believe this is us working together on a project, and it's going to take time, and I'm not going to hit the mark straight off, and we're going to have this, we're going to change that, we're going to up the dose, we're going to stop it. And you can just see them going, I'm clinging on for dear life, believing you, but that might run out if we don't get somewhere quickly. Do you know that feeling?
Yeah, definitely. And I think the other thing to remember, as I just said, my discipline is the part of veterinary medicine that deals with the triad of health. So it doesn't just deal with the physical. And this is something that's very, very well recognized in human medicine and treatment of chronic pain. And they call it the biopsychosocial model. So bio is our physical health component, as we would talk about it in veterinary behavioral medicine. The psycho is the emotional component. And then you've got this social component, which is basically the learned or the habitual or the conditioned patterns, which we would talk about as cognitive. And I think we have to be really careful with using biopsychosocial model for our patients. It doesn't quite work. We need to find another term. But what I like to look at it as, it's the triad model that physical pain, has a physical component. Yes, of course it does. It's a neurological sensation. It's a sensory input and a motor output in response to that. So of course it's physical. That's the bio bit. But the emotional side of it is equally important, which is basically the fact that your bias of emotion. I'm not sure how familiar listeners are with emotional health, but emotional health has two what we call valences. So you can either be more protective in your emotional bias, so you have a pessimistic attitude to life, you look for the potential for there to be danger, which would trigger things like fear, anxiety, and you get you're emotionally challenged by failure, which leads to frustration. So there's these emotions are all normal, absolutely normal. And we should all have a balance of protection and then engagement, which is the other side of emotion, which drives you to want things, to approach things, to engage with things. And to be healthy, you need a good balance of those. It's not that you want no protective emotion or we'd all be dead, but you need to have that balance. And what we aim for in both, whether we're rearing a child or a foal or a kitten or a puppy, doesn't matter, rabbit, kitten, doesn't matter. What we're aiming for is for them to have what we call a positive emotional bias. That basically means that your predominant emotional state is to be engaging, but that's not exclusive. Doesn't mean you don't experience negative or protective emotions, because when they're triggered in the right place at the right time, they are absolutely essential for you to survive. So we do need them. We don't want to live in a world that's free of fear, because fear is very, very important for our survival. But we don't want to be living with a bias that's always thinking the worst, that's always going to, I need to protect myself, because that's physiologically unhealthy. So what happens if you're in a bias of protective emotion and that is constantly happening? There's a physiological response to that. So that's going back to your physical health, which then starts to do damage through catecholamines, glucocorticoids, then starts to have an impact on what we call physiological responses within the body. So that's like the chemical pathways within the body that start to damage organs, for example. They start to damage your gut lining, start to damage your bladder lining, start to damage your lining in your mouth, start to mess about with your immune system. So then if that happens, if you're in that protective bias for too long and you can't rectify that, so your protective emotions should come, do their job and go again. If they come and stay, that's when there's a problem. And so what we're looking at is when we're treating an animal with a behavioural presentation, so it's not a behavioural problem, it's a behavioural presentation. It's what the behaviour is showing us. We're looking to see, okay, what is the drive for that behavioural response from a physical point of view, from an emotional point of view, and then the other part of it is the cognitive point of view. So pain has got physical, we're not disputing that. It's got emotional impact because pain is one of the protective emotions. So it is an emotion as well as a sensation.
People were blown away because when you said that to me, I was like, oh, what? Oh,
yeah. It's one of the protective emotions. So we talk about pain having 4 quadrants. So it has the sensory, motor, diagonal, connecting 2 quadrants. So a sensory quadrant and a motor quadrant, which are connected. So you get a sensory input and a motor output, which is your natural neurology, and which everybody thinks about in pain. And then you have an emotional and a cognitive diagonal as well. So the emotional part we've just talked about is the protective part, and then the cognition, which is more the social part of the biopsychosocial model in humans, is what influences the learning associated with that pain. So when you are in pain, there's something called classical conditioning, which is Pavlovian conditioning. If you remember back to being at school, it's Pavlov and his metronome and his food. So every time the metronome tone sounded, if food and the metronome occurred together, then eventually those dogs would salivate when the metronome tone was heard, even whether there was no food there or whether there was food there or not. And so emotions go through that form of learning, which means that anything that happens at the same time as an emotion becomes connected with it. Call it a conditioned emotional response. Now, if that emotion is pain, then wherever the animal is, so its location, who it's with, what it was doing, at the moment it experiences pain will become connected through this state of classical conditioning. So it's really important to remember that when an animal is in pain, that whoever is with that animal at that point in time, whoever is manipulating that leg at that point where you induce an acute on chronic pain response, because that's what you do. So as you manipulate, it's actually the acute pain that leads you to see that reaction, because you create an acute response on top of the chronic response. So yeah, it's very complicated. And if you only treat the physical with the medication, you won't be successful. So medication is not the only thing you need to do. You've got to treat the other parts of it. And that means adjunctive therapies. It means emotional treatment. My dear friend and colleague, Sarah Fisher, works on using free work as a way of really training the neurological pathways to calm down, because one of the things is they're all rushing as well as sending extra information because of this sensitization effect. So she uses more of a behavioral input. So do something which is going to change your emotional state and therefore aid your pain. And we do things as well that are environmentally, socially, physically, environmentally changing that individual's emotional state, because that will influence the pain. But also use cognition as well, because cognitive changes can also help, as well as physical therapies, which are going to be dealing more with the physical part, so all that tension in those muscle bundles. And don't think pain only comes from the broken leg. It comes from the muscle tissue, the fascia, all of that. The soft tissues that hold the body together are also capable of being in pain. So physical therapies, massage, physio, hydro, acupuncture, all of these things are so important. We can't treat pain monomodally. We can't do that with drugs either, which is the other thing we should talk about. But you can't do that with pain in general. You cannot treat pain in a unidimension. It's not possible because it's far too complex for that.
No, it is. And it's lovely having somebody like you kind of like saying that to all the people that are listening, because there is a tendency for people to come in and think that there's going to be a quick fix. And they want to have a pill that's given for 2 weeks and then it's all resolved. And that's another conversation I have probably 2 or 3 times a day of pain is really complex. And, this is just the starting point. And we're going to see how your dog responds. And then we're going to adapt and we're going to add and change and twist. And there's definitely in our UK society still a belief that it's all about a drug. And kind of drives you a bit crazy because there's so many other variables that can influence. So before we crack on with cats, which is what's the topic of tonight, I just wanted you to kind of like try and get people to expand their understanding of how pain can influence us, our outward expressions, but also we can influence pain with many different aspects of our life. I just want people to be open to it because I know what happens. I'll be in the consult room. I've talked about the drugs and then they glaze over. They're just gone. And I'm like, no, come back. Let's talk about rugs and toys and walking and leaves. And they're like, no, you finished talking about drugs. I'm out.
Yeah.
Help me.
I think you've just said something really important, the order in which you say it, because they're waiting for the drug information. So I'd give that last rather than first. Because you are interpreting the medication being the end point rather than the starting point. We understand it's the starting point, and actually we do need the medication. But if you talk in that different order, so you talk about the fact that the pain is an emotion and it's also physical, the rugs, the environmental modification, the things we do to modify the environment, which is not the same as optimizing an environment, but it's about making it tailored for a particular condition. So for cats, we're going to talk about in a minute, giving them steps so they don't have to jump onto surfaces. They can go up a ladder of stairs to get there instead, or a ramp. Those sorts of things, they are aiding the physical side of it. So you could say, I don't know if you've ever had a slip disc or a bad back, but did you find it difficult to walk upstairs, or did you find it difficult to did you still jump onto your bed, or did you still go to step aerobics, or did you give it a miss for a couple of weeks, and try and get some idea of some connection with what that felt like. And no, I did modify my life. I did. Yeah, no, I didn't go to step aerobics for a few weeks, and I went up and downstairs far less. I'd make sure I brought everything down in the morning so I wouldn't have to go up and down the stairs too many times. Those are modifications. Remember that we are far more autonomous than our companion animals, and I think that's sad. We need to actually remember that every individual needs autonomy. But we talk about a lot with humans now. We talk about agency and autonomy in humans far more than we used to, and that is good and in children absolutely crucial. But we need to talk about it in non-human animals as well. They also need agency and autonomy. And so one of the problems of being a domestic pet is that most of the decisions are made for you.
Yes.
We make the decisions about where they're going to be and what they're going to be doing and how busy their day is and how much sleep they're allowed to have and all of those things. We decide that because we have this very, very strange, I will never ever understand it, perception that humans are special. I honestly do not understand it. I can't get my head around it. We are animals. We're just animals.
Yeah.
We're just a different form of animal, but there is this unbelievable human arrogance
that
we are somehow special we're not. We have evolved in a way that has allowed us to have more control over the environment that we live in than other species. But that doesn't mean that we are special or away. So I talk about human animals and non-human animals because I really can't stand the distinction that, well, that's a human and that's an animal. What do you think a human is? It's an animal. It's like, it's bizarre. I will never ever understand it. But I think if we can try and get away from that, then if you understand that treating a human animal who has pain means you need to make changes to your environment, adjust the things you do, then it makes logical sense that if you're a non-human animal who is in pain, you also need to change your environment and modify it. But if you're a companion animal, that autonomy is not there because they don't have opposable thumbs. So they can't put the rug on the floor. Therefore, it's our responsibility as an animal who has evolved in a slightly different way, does have opposable thumbs, can pick up a rug and put it on the floor, and also has some level of cognition, which isn't superior, it's just different, has a different sort of cognition that can actually make those decisions more readily than the dog can, because the dog has other skills that we don't have. It's not that we're better, we just have different skills. And so that means that if we use our different skills to assist the non-human animal to modify that environment, that makes perfect sense.
Yes.
You do that for a human, you'd help the human to modify their environment. You'd put a stair lift in for your granny. Why would you not modify the environment for a non-human animal who's in pain?
Absolutely. And it also fulfills the other category where lots of owners don't want their pets to be on high doses of different medications. And
just a caveat there, I do think we need to remember that in order to do some of the physical therapies effectively, so things like physiotherapy, for example, you cannot do that if the physical sensor motory part of the pain is too significant. It's not possible. So you do have to use the pain relief medications, which are dealing more with the sensory motor part of the process to get that pain under control in order to do the muscular work, the work with a laser, the exercises, because you cannot do those exercises if you're in very high levels of physical sensation of pain. So we mustn't in behavioural medicine, we work with physical, emotional, and cognitive health, which are of equal importance.
Yes.
What's really important is we don't go down but actually the more important thing to do is the environmental stuff and the emotional. No, then nothing is more important. They are equally important.
Yes. Yeah, no, I totally agree. I do still find it hard to persuade owners that these sort of changes are an essential part of the plan. But so having talked about pain being emotion, having talked about how there's many different influences to the pain experience, having talked a little bit about you can come back in, Evie. You can come back in. She's so lovely. It's not her night on call. She's here with me because it's mine. So we've been talking about all of that, and we're hoping with this chat, before talking about cats, we really expand people's understanding that pain is not just a pathway. It's not a yogurt pot and string situation that you can just use a drug and cut the string, it's done, sorted. There's huge amounts of variables that influence it. Let's now move on to cats. We've had somebody go straight in for a potent question. Is there one or two inappropriate behaviours that may be common when a cat is experiencing pain? So can we expand on that? Because one or two, that's kind of like, oh, it's tiny. Where can we go with that one?
Okay, the first thing to remember whichever species you're looking at is that you need to always interpret everything in the light of their natural species-specific behaviour. And one of the big problems with cats is that they are not obligately social like we are and dogs are and horses are. And that causes some fundamental changes in the way that they respond to pain and to lots of other things. But it means that when they are in a situation of being in pain, it is far more likely that they will select what we term in the Heath model of emotional health inhibition, which is a shutting down of expression whilst you gather information. So they're not shut down, they are gathering information. They're very aware of their surroundings. They're finding out what's around, what's potentially dangerous, what's potentially beneficial, but they're not doing anything. And so absence of behaviours has been shown to be very important in diagnosing chronic pain in cats. It's also important to dogs, though. So I don't want us to kind of go down the rabbit hole of, that cats and dogs are completely different. They're not. There are overlaps, but there are very, very fundamental differences in their natural behavioural, what's called their ethology, and the root of that is this difference between an obligately social mammal, so that's a social mammal that needs social contact in order to survive, so that's us and dogs and horses, for example, and cats who are non-obligate social animals. They are sociable, they enjoy social interaction, but they don't have to have it to survive. And at the end of the day, they are what we term solitary survivors. What that means is that the survival of the individual is entirely within the paws of the individual. It's not a shared responsibility. That means that you've got to be really careful never to show your vulnerability, because your vulnerability will indicate that you're not able to look after yourself. That's going to make you very, very vulnerable in a physical sense, even from being predated. And I think people forget cats are actually prey animals as well as predators. And we're very familiar with cats being predators because we play with them with predatory play, and we get upset when they kill birds and mice, and so we know they are predators. But I think we've really forgotten, because of domestication and cats being protected by living with us as their caregivers, that they are actually a prey animal as well. And that influences their behavior. Rabbits we think of as prey animals because they're not predators. So therefore we think of them as prey. And therefore we understand that rabbits will be more likely to be protective of themselves. They are social, those, and they're obligately social, so they're different from cats, but they are similar in that they are prey animals, and therefore they have this acute sensitivity to the potential for danger. If you add to that the cat is a solitary survivor, they've got an acute sensitivity to the potential for danger, but know they have to deal with it on their own.
Right.
And therefore they're not going to clearly indicate that they are vulnerable in any way. It's not just pain, any disability that they have, painful or not, they don't shout about it. They don't tell everybody that they're feeling bad, because the reason we do, dogs do, horses do, is because we have a group living structure that means there is assistance available. So it's good to indicate to your friends and your family that you're not feeling well, because they'll go to the shops for you and they'll bring you some milk and they'll cook you some tea, or they'll do something, because hey, sorry, I'm going to burst that bubble of Evie being lovely and say she's only doing it for herself, because you are actually doing it for yourself, because because the friendship helps you survive. So if Hannah is incapacitated and vulnerable, that actually damages you as well. So your interests to bring her milk, make sure she has food, make sure she doesn't die, basically, because if she died, you would be less capable of surviving than when she's alive. Does that make sense, though?
Perfect sense.
So if you're a cat, no point in telling the other cats that you're unwell. They will not go to the shops for you. They'll just go, oh, really?
Yeah. On your own, mate.
And that's significant to me. Why?
Yeah.
Why are you telling me that? That has no impact on me whatsoever. You're ill. Fine. Thanks.
Yeah, I see that with flea and worm, actually.
It's not important.
I know you're my sister. Take care.
Yeah. And again, it's not a bad thing. I absolutely adore cats. I think they're most amazing creatures. And it's not a bad thing. I think because we're socially obligate, we immediately see that as selfish and snooty and arrogant, and oh, they're not very nice. Well, yeah, they are. They're lovely. They just don't do it our way.
Yeah.
And it's a bit like, it's like cultural differences between people, isn't it? That, if you're not doing it my way, then you're doing it wrong. Well, no, there are a million ways to do everything, and cats just do it differently. So it's not a nasty, I don't care about you. It's just that you wouldn't care about me either. It's not a bad thing. It's just we're all individuals creating our own survival. So the most important thing to every single cat is, how am I going to survive? Okay. How am I going to get through this?
Okay. So then for people that are quite new to this field, it's an impossible task. List off some of the presentations that you may see with that foundational drive in a cat.
Some of the really common ones are not grooming, so self-care behaviours becoming absent, and that's because they physically can't groom to some extent. It's their actual movement of the joints, for example, that hurts. In osteoarthritis means they physically can't groom themselves. But it's also because they will shut down any behaviours that are in terms of survival are the least important.
Yeah.
Because what is important is to survive, and energy is neither created nor destroyed. It's finite. So you have to make sure you maintain it at all times. You conserve it as much as you can. Could be good if humans learned that one. But anyway, so what you need to be doing is thinking, which of my behavioural responses are actually necessary? Well, actually, grooming myself is not really absolutely necessary at the moment. That's something that can go. So if you start seeing a cat who is more unkempt than usual, cats are fastidious about their cleanliness and their grooming in their healthy state. So if you notice that they're a little bit more mucky than they used to be, they don't seem to be grooming as much as they used to be. They've got white patches and they've always been sparkling white, and now you're noticing, oh, it's funny, I've never seen you with a muddy patch on your paw before, or those sorts of things. It doesn't have to be a long haired cat where you might notice tangles and things like that, but anything that you see that goes, that grooming pattern's not normal, or that he doesn't groom anything like as much as he used to, or I'm noticing he's more dirty than usual. Particularly things that involve movement for OA. So if he's got a dirty bum and things like that, because they normally are very, very fastidious about cleaning themselves up after toileting. So if there's little bits of crusty stuff around their bum hole, then think that's a bit odd. It could be a GI thing.
I've never seen that on one of the ads of pain awareness in cats. Crusty bits by the bum. I'm going to let Zoetis know, because I think they're going to
take the bum hole. So self-care, is he looking after, is he or she, are they looking after themselves in the way I would expect them to?
Yeah.
And the next one I would look at is, are they accessing three-dimensional space as I would expect them to? So a cat lives in what we talk about as a three-dimensional world, and we live much more as a ground-dwelling species. So if you just look above you now in wherever you're sitting, and there will be a lot of wasted space. So we don't use vertical space more than bookshelves. That's about the only time we do. Bookshelves and wardrobes, we actually make them go into a vertical space, but we don't actually go there. We then use a step to get to the books. Well, you do if you're as short as me. You get a step to go up to the bookshelf to get the book down. But we don't sit on the top of the bookshelf. I've not seen many people doing that.
No, not normally.
We don't generally climb into a wardrobe
now
to get onto the shelf at the top of the wardrobe. But if you're a cat, that's exactly what you do, because they have two requirements that are important. One of their fundamental needs is to have a safe place.
Yeah.
And safety for them is being in a position where you can basically keep watch over your environment, because you're a prey species, and a prey species must always be on the watch for potential predators. So cats like to get into an elevated position where they can survey all of the land around them, and they can see further, so that they can see whether something's coming that might be dangerous. They also, when they are actually going to sleep, because they are vulnerable, because they don't have friends to go to the shops for them, they don't have that culture of a group identity. If you're going to go to sleep as a prey animal, that's a very vulnerable thing to do. Mm-hmm. So you need to make sure that the place you're in where you're sleeping, you're not likely to be found. So if you go high up and you make sure you're also in an indentation, then you can get inside that and make yourself as non-visible as possible, and then you can sleep better. Mm-hmm. So they like to get up high to observe. They like to get up high to sleep. That would be in different locations. And they also have a need to patrol. So to make sure they are constantly looking at their environment for those potential threats. That's the predator, the prey animal in them on the one side, where they're looking for predators, and then of course they also need to hunt to survive, so they need to be looking for prey. So they're looking in both ways when they're doing their patrolling around their environment. And again, if they can do that patrolling from a safe vantage point, i.e. high up, then they are much safer than if they're at ground level.
Yeah.
So if we then look at what changes when they're in pain, obviously physically it is difficult to jump, jumping up is difficult if you've got issues with your lumbosacral area or your hips. And also for cats, we know that the elbow joint in OA is very, very commonly affected in cats. And then they can't jump down without being in pain. So they will stop doing that. So they will lie on the floor more than they used to do. Yeah. They won't be in those elevated positions, or they will hesitate before doing so. So they'll go and then they'll wait, and they've got to get mind over matter. They've then got to get themselves psyched up emotionally to go, I really, really do need to get up there, because pain is the protective emotion that's saying, don't jump, it'll hurt, don't jump, protect yourself, don't jump. The other side is going, desire seeking, that elevated place that they will allow me to sleep, that elevated place that they will allow me to feel safe. That elevated place is something I need to engage with. Okay. So now I've got a dilemma, haven't I? Do I want to engage with that resting place or that patrolling area or that vantage point more than I want to protect my joints from being painful? And they sit in this hesitating stage. So you'll see them, they'll come and sit beside where maybe they've always jumped up on the counter to get food, and you'll see them sitting looking at the counter, and they're basically weighing up that emotional balance of which of these is more important to me at this precise moment in time. And then if it's tea time, they'll go, no, sod it, I need to eat. And they'll jump, and they'll get up and they'll go, oh, the cat's fine, he's still jumping on the surface. But did he hesitate before he jumped? Or did he just run in from the garden, jump straight up and start eating? Those are two very, very different things.
They're really different. It's very hard for owners, though, isn't it, at times?
It's incredibly difficult, because it's incredibly subtle, but it's an important difference.
No, totally. Because I was just thinking, flea and worm at the moment, they move so agile. 1 minute they're there. They're there. You don't even see them do it. You're like, and then, but when you pick up cats that are carrying pain, as you say, it becomes just a little bit jolty, a little bit like time standing still a little bit. It just slows down. It's not a instantaneous action, isn't it?
No, absolutely. Yeah. So I think loss of self-care and changes in positioning of where they are safe and where they're patrolling and where they're resting, those are things I would really point out to.
That's brilliant. Well, you've managed to answer Bonnie's question, which is great because she was asking to help staff and volunteers in shelters, and hopefully that's really helpful to you, Bonnie. She then points out this, and I don't hear cats vocalise very often. Do you? In the nature
main time we hear them vocalise is when they have cognitive dysfunction or dementia, and then they vocalise like crazy. They also vocalise a lot when they have learned to do so. So a lot of dogs are cats. A lot of cats are conditioned to vocalise, so they learn to vocalise. So things like open the packet of Dreamies, please, or open the door, please, or open the fridge, please, or whatever. That's a conditioned response. Vocalization in cats is less because the majority of vocal signals are come here signals. So they are the mating calls, which are come here for a specific reason, obviously. And they are the meows and the trills and the chirrups, which are the hellos and the social engagement vocalizations. And because they are solitary survivors, they don't chat as much as individuals who are solitary obligately social. Obligate social animals communicate vocally a lot because it's very important to do so, because you have to keep that going. Whereas for cats, actually communicating isn't really that important with anyone other than yourself. Once you're an adult cat, it's quite minimal. And so vocalization is less common, other than the third set of vocalization. So you've got the closed mouth purring, trilling and chirruping. You've got the opening and closing of the mouth for the meow and the sexual calls. And then you've got the third form of vocalization in cats, which is what are called the strained intensity calls or the high intensity calls. And they're the ones where they keep their mouth in a fixed position, and this musculature on either side of their face is totally tensed up, and they hold their mouth, it doesn't move while they make the sound. And that will give you things like the hiss, the growl, the spit, the pain shriek. All of those are in that category. And they are the go away, leave me alone, get out of my space type vocalizations. So you will only hear those if a cat feels that their space is in some way invaded, if they feel they don't have a safe place, they can't feel safe and secure, then you will hear strained intensity calls or high intensity calls. If you are sexually active, you'll get sexual calls, because cats are solitary survivors. You can't actually have sex on your own if you're a cat. So therefore, you need a member of the opposite sex if you're a cat. So what you then need is to be able to quickly and distinctively show that at the moment I'd like you to come close. 90% of the time I want you to leave me alone, but now I want you here because I actually so they do this very, very distinctive, very broad vocalization that's got a lot of variation in pitch, so it can travel over huge distances, because there might not be an entire tom near to you if you're a female, and vice versa. So you've got to be able to get that message out good and strong and over a long distance, and you've got a limited time in which to do it, because you're seasonally polyestrous. So although if you're a cat, you're going to be an induced ovulator, and that's nature's way of making sure you've got more chance of it working when you've got so little opportunity. So you don't want to be messing around with potential for the egg not to be around at the right time. That would be stupid. So you don't release it until you know there's going to be some sperm available. So the vocalization is part of that whole way of mating. And so those signals are definitely heard loud and clear if you've got sexually active cats. And then we've got the trill and the purr, trill, chirrup and purr, which are from the other set, which are to do with contentment. They're to do with inter-cat communication, particularly between offspring and their mum. But they're also about self-communication. Cats will purr to themselves. And we hear that a lot in veterinary practices. And it's been likened to singing on the way to the dentist. So it's a way of self-soothing. So when they're in the veterinary practice and they're purring, that doesn't always mean they're contented. But they're trying to make themselves contented. They're going, it's fine.
Like Julie humming the other
Yeah.
day. Our receptionist couldn't stop humming the other day. We're like, you're having a bad day, aren't you?
Yeah, it's self-soothing, which is a bit worrying a receptionist. But yeah, so the question was about vocalization when they're jumping, wasn't it?
Yeah.
So it'd be very unusual to have vocalization during the act of jumping, because none of those three categories would apply other than pain. So the strained intensity call of a pain shriek would be part of that, because that's the only class of vocalization that would fit, unless the only thing I would just say a caveat on that, and biology is always full of caveats, is that if that cat was on an elevated location and saw something that it had a desire-seeking motivation to engage with, which was social, so a person or another cat it had a relationship with, it might vocalize on its way down. So it may jump and meow at the same time.
Yeah.
So you might get a vocalization in that action.
Yeah. Jesus. We've done 50 minutes just talking about that. It's crazy. See, I know, right?
Yeah,
and this is what I was trying to like.
Wow.
I think people don't realize that, just to high five you became really passionate about behavior 30 years ago.
My practice was 30 years old last year, and I was in general practice for 4 years before that. So, and I was doing behaviour within general practice before I set up my own practice. So, a long time, yeah.
And you got into behaviour through dairy, wasn't it?
Yeah. My route into behaviour is a real is a very long story, but basically through welfare. And so my whole passion about behavioural medicine is because of welfare, and that started because I'm a Cheshire girl. So my family had no connection whatsoever with the veterinary profession. I didn't even have a pet till I was 13. Well, I had a goldfish, which I said to my mum didn't count. But so I had my first dog. No, he was called Flicker, and I do remember him, and he was lovely. But my first companion mammal was a dog at the age of 13, and I begged and begged and begged and begged and begged for at least 10 years to get that. I think from the moment I could speak, I want a dog, I want a dog, I want a dog. So I wasn't allowed a cat because my mum hated them. So I had to wait till I left home and went to vet school before I got a cat. So I had that situation that nothing at home was agricultural, but I had a real passion for agriculture right from a very early age, which I think, my mum and dad took me on farm holidays in the days when, people didn't go on holiday like they do now, never went abroad or anything like that. That was unheard of. And so one thing that was quite a nice holiday thing for families was staying on farms. It was a very common thing. And then the children would be invited to get involved in the farming things. And I was always, as soon as we went and stayed on a farm, I'd ask if I could go out with the farmer in the morning, and I'd be up before everyone else and dressed and out and milking cows and doing anything I could to be outside on the farm. Then family would want to go and visit the local area and go on days out, and I didn't want to leave the farm. So it's like, just leave me here for for a week was 2 weeks, and then you lot, you can go off and have your fun, but I want to stay here on the farm. And that all built into working on a dairy farm as soon as I could. As soon as I was old enough to work on a dairy farm, I had a job at a local farm. And a very, very important person was the stockman there, who I never got the chance really to tell him exactly how important what he taught me was. Sadly, he's no longer with us. But I had no concept of how ahead of his time he was. And he was talking about welfare, not using the terminology perhaps, but he was talking about his cows being individuals, about his cows having feelings, and about if a cow didn't come into the parlour in her usual order, he'd be worried about her. What's the matter? What's wrong with you? If she didn't want to lie in a cubicle, he'd spend hours out in the cubicle shed, and I was with him, looking at it, lying in it, looking at the draft, seeing why would she not want to lie in this cubicle? What's wrong with it? I've bedded it down. There's something wrong with it. She wouldn't not lie in it for no reason. There's got to be a reason. And I was brought up with that. And I actually thought that was normal until I went to vet school. And I got to vet school and went, oh,
yeah,
people don't actually talk like that. And John Webster of the Eden book, Beyond Eden, or I can't remember the full title of it, but he wrote a book about animal welfare, and it was absolutely revolutionary. And he was at Bristol, where I was a vet student. So people at Bristol started talking about welfare, and the Bramble report had not long come out, and all of those things. And I sat there thinking, why are they acting like this is new?
Yeah.
Since I was 14, that's what I've heard. Yeah. That's exactly, we should treat them as individuals. We must make sure they've got everything to fulfill their natural species specific behaviour. I'd been told that from the age of 14 when I started working on a dairy farm, and I was like, this is a bit weird. Yeah. These people are talking like this is revolutionary and new. So it started in dairy because that's where I was immersed, and then
it's grown. It's animals. Just, and it's you've had quite ups and downs, haven't you? Because I think we're still, as a profession, not great at bringing in the emotional impacts of clinical conditions and emotional impacts on clinical conditions. But it's coming good now, isn't it? There's a lot more movement in this area.
It's getting better. Definitely getting better. Yeah. And are you still on call?
Still on call.
Busy night.
So much fun tonight. With that in mind, let's just quickly deal with 2 questions, and I'm going to let you be on your way. I love this one, and you've only got 1 minute to give somebody some advice, because this is a common problem.
Right. Yes. So as nurses, I think you very, very commonly suspect pain because you're with them in a different context. You spend time with these animals and you see those very subtle changes. So what you then, it's gone the question, but I think it was, how do you convince the owner to see a vet? And I think actually maybe the way to do that is not to do it that way around, but work so closely with your veterinary professional colleagues. And remember, vets and nurses are veterinary professionals, and we are equal partners in the veterinary profession. So if you have, as a vet nurse, suspected that there is pain, and you speak to your veterinary colleague who should be treating you as an absolute equal, then you should be talking to them first and say, see this patient, absolutely convinced we've got a pain issue here. And then it's the vet going to the caregiver, not the caregiver going to the vet.
I agree. I think that's really powerful, is if the vet actually steps beyond that boundary, says, my colleague believes there's a problem, how can I help you? It's a teamwork, isn't it? Yeah, definitely.
Yeah,
and we've started making sure that we put on the diary to phone people back. So if there's a suspicion, I'll be like, I'm going to leave you to think about this. I can see that you need to process it, and I'll give you a ring in a week. And things like that. That makes a massive difference. Yes. So put it onto your diary, telephone agenda. And it might be a 1-minute call. It might be a 2-minute call. We don't know, but it's working wonders for us, definitely.
Yeah, and nurses are amazing at that, because they're good at communicating, and they have that approachability and empathy that sometimes is not as evident with veterinary surgeons from the caregiver's perspective. I think the caregivers worry about wasting the veterinary surgeon's time. Not that they should ever, they just shouldn't undervalue nursing time either. But there tends to be a differential in the caregiver's perception, which is our fault probably as a profession. But so I think that's really important. And one of the things you were just saying as well before, we've talked tonight about the sorts of behavioural changes we might see in cats that are in pain, but also remember that we may see physiological changes as well. So that cat that has FIC may have pain from its bladder now because it's got FIC, but it may also have osteoarthritis, which has caused it chronic pain, which has led to physiological stress, which has led to a breakdown in the mucosal barrier in the bladder, which has led to having FIC. So the fact that it's got FIC doesn't exclude it having some other pain source that led to its physiological stress that led to that condition.
Yeah, definitely. And I think that's something that I'm actually really enjoying in the last few years is, say a dog's come in for x-rays because they suspect a cruciate, stop, look at it again, look at everything. And I would say probably 70-80% of the time I'm finding other things that do need to be attended to. And it might be some dental disease, some ear disease, and but just focusing down on the x-ray, I'm doing that dog a disservice. If they're going to be sedated for x-rays, let's see what else is needed as well.
And actually, as a veterinary profession, we should be really proud of the fact that we are trained in all disciplines, in all species. And that's a real amazing advantage of a veterinary degree in the UK, is that it gives you clinical transferable skills. And it's to just, and even now as a specialist, obviously as a specialist, I start to hone in on more things, but I'm very fortunate because behavioural medicine, you can't do that because it's about the health triad. So if anything, you get broader minded by doing behavioural medicine, not narrower minded. But I think we do need to, as veterinary surgeons, just always remember that is an animal, and an animal who is a complete being. I know when my youngest son was very, very poorly as a child, and I spent a lot of time in hospital with him. And one time when we were in hospital, there was a lady in the next room to me with her son who'd had a comminuted femoral fracture. And the surgeon was coming around to see him to evaluate how he was doing. And the x-ray was up on the x-ray viewer in their room. And she said the surgeon came in, looked at the x-ray, looked at the leg, and said he can go home, and left the room. The child had an oxygen mask on because he had pneumonia.
Yeah.
And so the nurse said to the mother just looked at her in complete shock. And the nurse said, what he means is his leg can go home.
I love that. It's so true, though.
Yeah, absolutely. And it's like, that is so important, never to get to that point where we are so focused on a piece of anatomy that we forget there is a non-human animal attached to that piece of anatomy. Yeah. And that is a living, sentient, thank goodness. Yes. We now have actual recognition now that these non-human animals are sentient beings. And that sentient being is attached to whatever, to that cruciate ligament, to that uterus that you're removing, to that skin wound that you're treating, to that tail wound you're treating. There is a sentient being attached to that.
No, I love it. I love it. And I'm gonna call time on it at that point, because I think it's a really powerful endpoint. Bonnie's your newest fan, and I totally agree.
Speak from Bonnie.
Because it's seriously like, an hour's gone and every word.
It's gone so quickly.
I know, right?
Yeah, I didn't know it had gone that long.
But I really, really hope that people will kind of start expanding their mind just from the physical diseases that we deal with, and look at the pet's previous experience, their journey to the practice, their waiting room experience, their consultation experience, their hospital experience. Everything counts.
So complex.
It is very complex, and it is hard work, and it is time consuming, but the reaping the rewards is worth it, isn't it?
Oh, definitely. Yeah.
Well, thank you.
Very
I definitely owe you one. I don't know when I'm going to bump into you again, but soon, hopefully.
It's been a pleasure.
Thank you,
thank you very much for inviting me.
Not at all. I better go and do some on-call work now.
Yeah, absolutely.
Yay! Thank you so much, Sarah. Everybody loves you. Please keep saying your thank yous, guys, and we will see you next week. See you later.
Bye.